Hi everyone, I'm Kieran. I'm one of the fourth years at Queen's, and I'm going to be starting this lecture today, which is on electrolytes and acid-base balance. So in terms of the regulation of electrolytes and acid-base, deranged pH and electrolytes can lead to deranged function, and equally deranged function can lead to deranged pH and electrolytes. So there appears to be a reciprocal relationship, and as such, there's a lot of feedback and regulatory mechanisms in place to prevent the dangerous sequelae that can occur. So in terms of what this lecture will cover, we're going to be going over acid-base balance in terms of respiratory and metabolic disturbances, renal and respiratory mechanisms of control and compensation, and then the causes and consequences of chronic acidosis and alkalosis. And then we're equally going to be looking into potassium regulation, renal and non-renal handling of potassium, and the causes and consequences of hyperkalemia and hyperkalemia. Depending on the time, we might also go into calcium regulation and iron regulation, but if not, I've covered these with some details on the slides for you to go over in your own time. So yeah, without further ado, we'll make a start. So in terms of what normal looks like, I'm sure you've all seen tables of values which you'd expect to see in a normal patient's blood. So for example, pH is normally regulated around 7.4 with a range of 7.35 to 7.45, hydrogen ions at 40 nanomoles, and so on and so forth. And you can see that electrolytes are regulated at different concentrations for the extracellular and intracellular concentration. Now, in terms of the acid-base status of the body, in the status quo, the pH is 7.4 for the extracellular environment and slightly lower, so more acidic in the intracellular environment. And these are related by different concentrations of hydrogen ions in the extracellular solution and in the intracellular solution. And the reason that plasma pH is maintained within a narrow range is predominantly because all the cellular processes in the body are exquisitely pH sensitive, so whether that's protein folding or enzyme activity. And acids and alkalis, particularly organic acids, are produced all the time by the body and also ingested. So therefore, that puts the body under stress and it needs mechanisms in order to cope with this. In terms of the contributors to plasma pH, can I just check, can everyone see the slide change?
I can't.
Okay. What about now? Great. Yeah, sorry about that. So yeah, so as I was saying, pretty much all bodily processes are exquisitely pH sensitive. So as a result, we have some mechanisms to deal with this. In terms of the contributors to plasma pH, we often consider that the bicarbonate buffer system contributes significantly. And this is shown here. So we've got water and carbon dioxide reacting to form carbonic acid in a reversible manner, which then dissociate to produce protons and bicarbonate. And putting these into the Henderson-Hasselbalch equation for a weak acid, we can see that modifying either the bicarbonate concentration or the partial pressure of carbon dioxide in the blood will have an effect on pH. Now, you'll also notice that the pKa of this reaction is 6.1. And the reason for that, you maybe think, okay, why isn't the pKa slightly higher? And the reason for that is that the body is constantly under an acidic challenge. So as a result, the body has adapted to use the bicarbonate buffer system as the predominant system, and equally we have other buffers in place, such as the phosphate buffer system. Now, in terms of how the body can be challenged in terms of derangements of pH, we like to think in a systematic manner. So we have our baseline arterial pH, which, as we mentioned, normally sits around 7.4 in the range 7.35 to 7.45. And the first thing we want to look at is whether someone is undergoing an acidosis or an alkalosis. So in acidosis, we would see it's a decrease below the normal range, whereas in alkalosis is an increase in the pH above the normal physiological range. And then once we've identified that a patient is either alkalotic or acidotic, we then want to find out whether this is either due to a respiratory cause or a metabolic cause. So respiratory causes will be due to changes in the ventilation rate, while metabolic will be due to either ingested or produced factors, which are altering the pH balance. So this can particularly be shifting that bicarbonate buffer system in either one direction or another based on the concentration of protons that we're producing. And in the hospital setting, it's really important to be aware of a patient's acid-base status. And so in order to measure that, we frequently do an arterial blood gas, where a sample of blood is typically taken from a patient's radial artery, and this is run on a blood gas analyzer so that a physician can find out the information about a patient's acid-base status in pretty much 10 minutes from taking the sample, or even less, to be honest. Now, in terms of what the body does to cope with these acid-base disturbances, we have three main mechanisms, and these all operate on different timescales, which can account for the different presentations and the different readouts on blood gases. So our first and foremost, the body's response is through buffering, and that's predominantly through this bicarbonate buffer system. But as I mentioned, there are some other buffer systems which also operate, which help to maintain that physiological pH around 7.4. We also have some buffering from other proteins present in blood, such as some plasma proteins and also hemoglobin, to form H plus HB. Now that operates on the scale of milliseconds to seconds, but then on a slightly longer scale of around seconds to minutes, we have pulmonary compensatory mechanisms, and that simply involves either increasing or decreasing the respiratory rate to either retain CO2 in the case of hyperventilation, and therefore increase the acidity of the blood, or to hyperventilate and therefore get rid of CO2 and therefore increase the pH of the blood. And then in the longer term, typically in the course of days, an acid-base disturbance can be compensated by the kidneys. And that's both through the processes of reabsorption of filtered bicarbonate, but also through excretion of protons, which are buffered in the tubular lumen by phosphate ions. And but this operates on a much longer scale. So and you can see that in variations in presentations with patients. So just going into those mechanisms in slightly more detail. Respiratory control of pH is related to the chemoreceptors on the ventrolateral surface of the medulla, which detect a change in the pH, and as a result, the respiratory drive will become altered accordingly. So in the case of an acidosis, what we want to do is get rid of CO2 in order to raise the pH, and we can do that by hyperventilation, by breathing really quickly. And on the other hand, in an alkalosis, we'd want to retain CO2 by hypoventilating. And then in terms of what the kidneys do, so these are some simplified diagrams of the processes. You can indeed go ahead and learn the transporters on the apical and basolateral membranes. But for simplicity, we have different cells which operate to reabsorb and to reabsorb bicarbonate and then secrete H plus. So most of the reabsorption of bicarbonate is done in the proximal tubule. Some is done in the thick ascending limb and some by alpha intercalated cells. And the process by which this takes place, as you can see, is these tubular cells express high levels of carbonic anhydrase. These catalyze the production of carbonic acid, which produces a proton, which is accreted across the apical membrane and reacts with filtered bicarbonate. And in this process, we also generate bicarbonate, which re-enters the blood. Now, we also, in case of acidosis, the alpha intercalated cells also operate to secrete H plus and regenerate bicarbonate. So in this case, we can see that essentially we're reabsorbing bicarbonate because of the net movement, whereas in this case, we're regenerating bicarbonate and secreting protons. There is also thought to be some contribution from beta intercalated cells, which essentially have an opposite arrangement and secrete bicarbonate, but the extent of this is still up for debate. Now, in terms of the derangements that we will typically encounter, we'll first go into respiratory acidosis. So, as I mentioned, respiratory acidosis is where we have where we have a low pH, and respiratory will be where we're retaining CO2. So we've got a high pH CO2, which is contributing to the acidosis. And so if you look at the bicarbonate buffering system, CO2 is increasing, which is pushing the reaction towards the right and generating more protons, therefore creating an acidosis. And so we increase the CO2, the pH will therefore decrease. And as a result, what the body acts to do is, so because the root cause is ventilatory, what will happen is over the course of a few days, renal compensation will kick in and bicarbonate will begin to be retained. So we'll then react with the protons and try to shift the bicarbonate buffer system toward the left. And as a result, will hopefully restore the pH back into the normal range. In terms of the causes, these are all going to be causes which result in hyperventilation, and therefore CO2 being retained within the body. So that can be things like airway obstruction or severe acute asthma, apnea, respiratory depression, for example, due to an iatrogenic cause such as opiates, lower respiratory tract infection, neuromuscular disease, for example, people, if the apparatus involved in inspiration is compromised, then of course that can result in CO2 retention. And then pulmonary disease. So most commonly you'll see this in patients with COPD. And really what you want to look for is if this is an acute attack, what you'll see is that the PaCO2 will be increased, the pH will be decreased, but the bicarbonate will be normal. But if someone is presented much later, you'll see that renal compensation has kicked in, the bicarbonate will be raised, and then the pH will sometimes be in the normal range. Now, on the other side, on the flip side, respiratory alkalosis is where we have a high pH and a low PaCO2. And again, conversely, this is due to hyperventilation, where we're getting excessive CO2 loss. Now, with excessive CO2 loss, we then get an increase in pH, I should say increase. And similarly, the body will react within the course of a few days to compensate through retaining bicarbonate instead. And it's important to note this is also a key mechanism which is used when adapting to altitude, because of course the partial pressure of oxygen decreases as you get to higher and higher altitude, so the body needs to compensate for this. Now, in terms of the causes of respiratory alkalosis, there's a variety which can result in hyperventilation, such as hypoxia, as I mentioned, due to altitude, an increased respiratory drive, which can be drug-related, or also due to a head injury, which can compromise structures within the brainstem, anxiety, pulmonary disease causing hyperventilation, and also mechanical overventilation. So, for example, patients in ICU who are placed on the ventilator can get overventilated and then have a respiratory alkalosis. And similarly, if we look on the blood gas, in the acute setting, you'll see patients with a high pH and a low PaCO2. But if they present more chronically, you may see that renal compensation kicking in, where bicarbonate is being retained, and as a result, the position of equilibrium of the bicarbonate buffer system may be shifted so that the pH is now back into the normal range. Now moving into the territory of metabolic pH disturbances. Metabolic acidosis is where we have a low pH and a low bicarbonate, and then the PaCO2 may be normal or it may be low in the case of compensation. So in terms of thinking about this step by step, what is happening, we start off by having too many acidic components in the blood, and this could either be being produced internally by the body, or these could be being ingested. And that results in a low pH and a low bicarbonate, as all those protons are reacting with the bicarbonate to shift that bicarbonate buffer system to the left. We then get ventilatory compensation, which acts in the short term, kind of seconds to minutes, and we'll get hyperventilation, where the patients will breathe very quickly to blow off CO2, and as a result, try to increase their pH back within the normal range. In terms of the causes of this, it's due to increased proton formation, for example, in diabetic ketoacidosis. Patients may inject acid, for example, in an aspirin overdose. There may be decreased proton excretion, for example, in renal failure, the alpha intercalated cells aren't working as well. And it could also be due to bicarbonate loss, where we want damaged renal tubules, in which bicarbonate is being filtered at the glomeruli, but it's not being reabsorbed. In terms of what the blood gas will show, you typically see an increased proton concentration and lowered pH, and then you may also see a decreased PaCO2 because patients are going to be hyperventilating. Typically with, you may see also with a metabolic acidosis that it may not be fully compensated. In terms of the causes of metabolic acidosis, what we can do is we can calculate this as far as you know as the anion gap, where we sum the sodium concentration and the potassium concentration, and then subtract away from this the chloride ion concentration and bicarbonate concentration. And what this does is it gives us a value in which we expect the normal range to be 3 to 11. But ultimately what it does is it gives us an idea of whether there is an excess of unmeasured anions. For example, an excess of acid, which is contributing to this acidosis. And what you want to consider is this anion gap raised, i.e. is it greater than 11 millimoles per liter? Is it within the normal range or is it reduced? And based on this, you can begin to decide what the, or begin to infer what the underlying cause of the base disturbance is. So for example, if there's a raised anion gap, there's an excess of acid production or ingestion, which is contributing to an extra, which is contributing to the extra protons. And there's a useful acronym called MUDPILARS, which you can look up, which gives you a differential of different causes of a raised anion gap metabolic acidosis. You may have a normal anion gap, that's typically where bicarbonate is lost from the gut or kidneys, and there's a raised chloride, which is compensated for by the extra cations, keeping the gap normal. And similarly, there's an acronym, HARDUPS, which you could go away and learn, but again, that's kind of small print, which will give you a differential for normal anion gap metabolic acidosis. And then finally, we've got reduced anion gap metabolic acidosis, which is usually when there's either low negatively charged proteins, for example, low albumin, hypoalbuminemia, or a high positively charged substance concentration, for example, high calcium or high magnesium. And then finally, we have metabolic alkalosis, which is where there's a high pH and a high bicarbonate, but a normal PaCO2, or sometimes a high PaCO2 if compensating. So I should say high. And if we think step by what's happening here, we have a reduction in the acidic components in the blood, which will raise the pH. We'll then get short-term ventilatory compensation. We'll get hypoventilation to try and retain CO2 and increase the proton concentration by shifting the position of the bicarbonate buffer system to the right. And then eventually we'll get long-term recompensation, where we'll increase the bicarbonate excretion to bring the pH back within the normal range. And almost always this is due to a loss of unbuffered protons, for example, through excessive vomiting. That could be, for example, due to bulimia nervosa or pyloric stenosis, particularly in infants, as well as renal losses. Or it could be due to the ingestion of alkali, for example, an antacid. So in summary, when considering different acid-base disturbances, the key components to consider are those relating to the bicarbonate buffer system. So using kind of the traditional model. So there is another model, the Stewart model, which considers the strong ion difference. This is related to, but this is a different hypothesis. In terms of the factors you want to consider, first of all, you want to consider the pH. Then you want to consider the CO2, see if this is deranged, and then look at the bicarbonate. And what that will tell you is, first of all, whether it's an acidosis or an alkalosis, Second of all, whether this is respiratory or metabolic. And then thirdly, whether there's compensation or a lack of compensation. I'll come back to that in a second. And so if you ever come across blood gases, that's a really useful strategy to use. So first of all, look at the blood gas. Is it an acidosis or alkalosis? So this is within the normal range. Then is the PaCO2, so the arterial CO2 value raised or lowered? If it's in the same direction as the proton change, then it's respiratory. So for example, if it's an acidosis and the pH is less than 7.35, then if this was a respiratory cause, you'd expect the PaCO2 to increase. And so if you see that the PaCO2 is increased, then this is going to be a respiratory acidosis. But if the PaCO2 is low, then this is going to be a metabolic acidosis. And actually what you're seeing is the compensation. And then finally, you want to look at, is the hydrogen ion change proportional to the change in the PaCO2? That's a very small print, but that's because we want to consider whether there's a mixed disorder at play. And we can also look at the bicarbonate, as I've been mentioning, to decide whether this is either an acute or a chronic picture. Is there compensation taking place or is there not? Now you may see in your exams, you may see these diagrams known as Davenport diagrams. I'm going to talk through the general features of them quickly. So on the y-axis, we've got the bicarbonate ion concentration with 24 millimoles, kind of the center of the normal range depicted. And then on the x-axis, we have the pH with 7.4, the normal set point. And you'll also see these curves, which indicate the values of pH and bicarbonate at a particular partial pressure of carbon dioxide. So here, for example, we've got an example line for a partial pressure of greater than 40 millimeters of mercury, and here for less than 40 millimeters of mercury. And you can see that in each of these disturbances, the set point is shifted somewhere along this diagram. So in a metabolic, if we look at the metabolic causes for, if we look at the respiratory causes first, we'll look at the metabolic causes first, sorry. In the metabolic case, there's no change in the respiratory in the acute phase. There's going to be no change in the partial pressure of carbon dioxide. So we're sliding along this line. And in the case of an acidosis, the pH will decrease. So you can see that the bicarbonate and pH will change accordingly. Whereas in an alkalosis, the pH will increase. And so you'll be looking at sliding along this line for partial pressure of carbon dioxide. Now, for respiratory causes, similarly, what you'll do is you'll slide along this normal non-bicarbonate buffer line to lines representing either lower partial pressure of carbon dioxide in the case of respiratory alkalosis, or higher partial pressures of carbon dioxide in the case of acidosis, where that carbon dioxide is being retained. And from this diagram, you can also see the rationale behind compensation. So for example, in a respiratory acidosis, the compensation is going to be the kind of loss of bicarbonate. So the compensation will bring you back to normal. And in the case of a metabolic alkalosis, for example, you want to retain CO2, so you'll shift back this way, and the pH will be normal, but you'll have a higher partial pressure of carbon dioxide. So that's the principle of the Davenport diagram. Sometimes it takes a little while to have a look at it and get your head around why the values are shifting along these lines, and then think about the compensation and how it will restore, or ideally restore, the value back to normal. So I thought it'd be useful to have a look at some practice to try and get your head around thinking through acid-base disturbances and then how the body attempts to cope with this. So first of all, we have the case of a 64-year-old gentleman with a history of COPD, who presents with worsening shortness of breath and increased sputum production. Now, first of all, we can look at the pH, which is 7.21, and have a think, is this an acidosis or an alkalosis? Well, it's an acidosis as it's lower than the normal range. Next thing we want to look at is the partial pressure of carbon dioxide. So in a respiratory acidosis, we'd expect the partial pressure of carbon dioxide to increase. Within a respiratory alkalosis, we'd expect it to decrease above or below the normal range. And in this case, it's increased above the normal range. So this looks like a respiratory acidosis. Then next of all, if we look at the bicarbonate is above the normal range. So what that suggests is that there has been some respiratory so the respiratory compensation is the renal compensation has started, but as you can see, this is not fully compensated because the pH is not back within the normal range. So you can see that the renal compensation has started, trying to retain bicarbonate in order to restore the pH back to the normal range. And we have another case here where we have a 67-year-old man with a history of peptic ulcer disease, presents with persistent vomiting. So first of all, we want to look at the pH. They have a pH of 7.56. Next of all, so if this was a respiratory, so an alkalosis, if it was a respiratory alkalosis, we'd expect the partial pressure of carbon dioxide to decrease. In actual fact, it's well within the normal range. So next of all, we're going to look at the bicarbonate. The bicarbonate is increased above the upper limit of the normal range. So this looks like a metabolic alkalosis. And that also fits with the clinical picture here. The patient is presented with persistent vomiting, meaning there's been a loss of unbuffered protons in the vomit, resulting in this metabolic alkalosis. So does anyone have any questions? Feel free to type them in the chat or speak out loud. If not, we'll move on to the next section on potassium handling. So similar approach here. First thing we want to look at is why is potassium handling important? And you can see that here, potassium has a very low concentration extracellularly, but intracellularly, it has a high concentration of 140 millimoles. So potassium is a very key intracellular ion, and that has very important consequences for the cell. So first of all, it's the main determinant of the resting membrane potential in excitable cells. It also facilitates the repolarization of excitable cells in response to an action potential. And then finally, potassium is also related to the intracellular pH due to electroneutrality principles. So for example, you'll see that sometimes when acid is lost, this is then exchanged for potassium in order to maintain the electroneutrality across both sides of the membrane. So I'll come back to the questions at the end after potassium handling. But in terms of why this is important, so you can see that clearly potassium is very important for the resting membrane potential, and then also in terms of the excitability of cells. So as a result, deranged potassium has very important effects on those excitable cells, on those cells that rely on excitability, so particularly on the myocardium. And you'll see that hypokalemia and hyperkalemia are associated with arrhythmias. And in terms of the distribution of potassium within the body, really we want to be looking at what the intracellular value of potassium is, but often we only measure the extracellular value, and that may not accurately reflect the body's potassium status. But just be aware of this fact that most of the potassium in the body is in the intracellular environment, relative to the extracellular environment, which only accounts for around 2% of the body's potassium. Now, in terms of how the body regulates potassium levels, we have a short-term and a long-term mechanism. In the short term, the action of the sodium potassium ATPase is working, which normally maintains a 30-fold gradient between the potassium concentration between the intracellular fluid and extracellular fluid. And then in the longer term, we also have regulation by the kidney. In terms of short-term regulation, so we have the sodium potassium ATPase. As you can see on the right, I'm sure you'll all be familiar with this. It's got that 3:2 stoichiometry, of sodium to potassium. And really the logic behind this is that if we have for example, if we have too high potassium in the extracellular fluid and we have a hyperkalemia, in the short term, what we can do is try and pump that potassium into cells where there's essentially an intracellular reservoir. And while we're not affecting the overall potassium status of the body, we're just shifting that potassium between compartments. So in the short term, if the potassium raises, the action of insulin will act to increase the activity of the sodium potassium ATPase, or also catecholamines in the body. So for example, adrenaline will act endogenously to increase the activity of the sodium potassium ATPase and cause that potassium to be translocated into cells. And you can consider that in kind of adrenal insufficiency and also in diabetes, this function will be disturbed. So they can be particularly at risk. So for example, individuals with diabetes can be, if it's unmanaged, it can be particularly at risk of potassium disturbances when exercising, for example. And in terms of therapeutics, we also do exploit this property of the sodium potassium ATPase in hospitals, for example, by giving patients, we can give them insulin or non-selective adrenergic agonists, or factors such as beta-2 agonists, such as salbutamol, which can cause that potassium to be translocated into cells and deal with that acute disturbance. Now, in the longer term, the body tries to actively change the potassium status of the body, and that's principally achieved by the action of the principal cells in the late distal convoluted tubules and cortical collecting ducts. Now, as with all electrolytes, potassium is absorbed along the nephron, and actually most of the reabsorption occurs in the proximal convoluted tubule, around 65%, with around 25 to 30% in the thick ascending limb of the loop of Henle. However, most of the regulated step actually occurs in the distal tubules and cortical collecting ducts. So this is kind of a constant process, isn't really affected by potassium status, but through the action of aldosterone, these distal tubules and cortical collecting ducts are really the key players here. And you can see an example of a principal cell found in this region here. So we've got, this is the basolateral membrane with the sodium potassium ATPase. On the apical membrane, we have the key channels here are the ENaC channel, which is a sodium channel, and then the ROMK and BK channels, which are potassium channels. And crucially, what happens is when potassium is high, this activates the secretion of aldosterone from the zona glomerulosa, I think, in the adrenal gland, and results in aldosterone acting on mineralocorticoid receptors here, for example, well, also in hypovolemia, it acts on mineralocorticoid receptors. And what that does is it increases the activity of the ENaC channel in the short term, but also increases the transcription of the ENaC channel and the sodium potassium ATPase, which increases potassium excretion across the apical membrane and actually reduces the bodily potassium in the extracellular fluid. Now, given that long-term regulation is principally carried out by the kidney, and this response is in response to aldosterone, we can think that a lot of the factors that affect aldosterone secretion will have an effect on potassium excretion in the body. So hyperkalemia has a direct effect by increasing aldosterone. Hypokalemia, conversely, will also have an effect by decreased aldosterone. I'll come back to acidosis and alkalosis. But other factors which deleteriously increase aldosterone in an unregulated manner, for example, Conn syndrome, primary hyperaldosteronism, and Addison's disease will increase aldosterone, whereas similarly, so Conn syndrome will increase aldosterone. Then we also have increased tubular flow rate. So what that does is when the tubular flow rate through the nephron is faster, that maintains the concentration gradient between the blood and between the tubular fluid. And as a result, that results in increased potassium excretion. And finally, loop and thiazide diuretics. So loop and thiazide diuretics are acting earlier in the nephron, for example, loop diuretics in the loop and thiazide in the earlier distal convoluted tubule. And as a result, what these do is they increase the delivery of sodium to these principal cells. And consequently, we have a greater exchange of sodium across the basolateral sodium potassium ATPase, which brings in more potassium into the cell, which has to leave across the apical membrane. So as a result, you get more potassium excretion. Now, on the other hand, we have some potassium sparing diuretics, such as amiloride and spironolactone. And what these do is they either, so amiloride directly inhibits the ENaC channel, whereas spironolactone acts as an antagonist at the mineralocorticoid receptor. So as a result, that role of aldosterone is, so as a result, it counteracts the role of aldosterone and will prevent that potassium loss across the apical membrane. Now, in alkalosis and acidosis, it's known that in acidosis, the theory is that high proton concentration actually interferes with the basolateral sodium potassium ATPase, and as a result, you get less activity of this pump, and so there's a reciprocal relationship between hyperkalemia, between potassium status and body pH status. And we'll look at that in greater detail here. There's also the fact that in acidosis and alkalosis, for example, in acidosis, we have the action of these alpha intercalated cells, which would be trying to excrete protons, and in exchange, potassium is brought into the cell. So as a result, in acidosis, as the body tries to excrete protons, potassium ions are brought in due to the principle of electroneutrality, and as a result, you get a hyperkalemia. Conversely, when there's an alkalosis, you're trying to retain you're trying to retain protons. So fewer protons are being secreted across, fewer potassium ions are being reabsorbed here, and as a result, you can get a hypokalemia. So there really is somewhat of a reciprocal relationship between acidosis, between pH status and potassium status within the body. And that's both due to the actions in the alpha intercalated cells, but also due to proton inhibition of the sodium potassium ATPase at the basolateral membrane. Now, in terms of the consequences of too much or too little potassium, in the case of too much potassium, we're thinking about potassium of greater than 5.5 millimoles. As I mentioned, really the harmful ones are the effects to the heart due to the importance of potassium for the resting membrane potential, and then also repolarization. So typically what you'll see is a variety of ECG signs. So you can see a flattened or absent P wave, a broad QRS complex, and then peaked, also known as tented T waves. You can also get some extracardiac symptoms such as vasodilation, hypotension, and also paresthesias. And in this case, in the hospital setting, really there is a need to treat these treat this hyperkalemia very rapidly. And the first line treatment is calcium gluconate, which acts to stabilize the myocardium. And then after that, what we want to do is look at actually removing the potassium from the extracellular fluid compartment. And so we rely on those short-term mechanisms to regulate potassium for that. So the IV glucose and insulin are administered in the body. Insulin to stimulate that sodium potassium ATPase to translocate potassium from the extracellular fluid into the intracellular fluid. And then glucose is given to prevent, obviously, the normal effects of insulin. And then we also have some other treatments which we can use, such as calcium resonium, but actually increasingly nowadays sodium zirconium cycosylate, which bind to potassium in the GI tract and prevent absorption. So therefore, we can try to lower the extracellular fluid potassium through those means. In terms of why we might get hyperkalemia, really we can think of kind of these three key reasons. So a very common reason will be the release of potassium from that intracellular reservoir, which will translocate into the extracellular fluid. And a key way that can happen is through rhabdomyolysis or skeletal muscle breakdown, or a severe crush injury and trauma, where cell lysis is going to result in release of all that intracellular potassium into the extracellular fluid, raising the potassium. You can get hemolysis, similar principle with the release of high intracellular potassium into the extracellular fluid, or for example, a diabetic ketoacidosis, so you get the acidotic effect, but also you have the effect from the lack of insulin, which is preventing the translocation of potassium into cells. Or we can look at renal causes. So we can either have decreased potassium excretion in renal failure, or potentially excess potassium intake. But this is typically iatrogenic, where people are being given potassium supplements such as Sandoz, or being given IV potassium. This is supplemented too much. Now, on the flip side, hyperkalemia may be caused by dietary insufficiency of potassium, for example, in anorexia nervosa, or increased renal losses of potassium. So that could either be due to lupin thiazide diuretics, because as mentioned, these increase the delivery of sodium to the distal convoluted tubule, and as a result, you're going to get more that sodium is reabsorbed at the expense of potassium being lost across the apical membrane, resulting in a hypokalemia. You can also get some primary renal dysfunctions. So there's Bartter syndrome, 5 different types associated with different mutations, affecting a couple of the transporters, particularly those in the principal cells. Gittelman syndrome, Bartter syndrome, that can kind of one of the main types affects the NKCC transporter in the loop of Henle, so it acts similarly to loop diuretics. Then we also have Gittelman syndrome, where we have a sodium chloride co-transporter mutation, which is essentially having a similar effect to thiazide diuretics, where the function is compromised. And then we also have Liddle syndrome, where we have an ENaC channel mutation, resulting in which can be associated with hypokalemia. Hyperaldosteronism can similarly be associated with hypokalemia, resulting in stimulation of that ENaC and the sodium potassium ATPase, and lots of loss of potassium across the apical membrane, or equally a low magnesium, which can increase the effects of aldosterone. You can also have increased GI loss of potassium, particularly through diarrhea, but also vomiting and laxatives, and increased transcellular movement. So anything drug-wise that can activate sodium potassium ATPase. So for example, salbutamol, which is taken by asthmatics, and then alkalosis. And similarly, this is effective. This causes some arrhythmias. So we get ECG changes such as ST depression, and T-wave inversion, and the presence of a U wave. So see the T wave here is inverted, and then we've also got this extra wave after and before the P wave, known as a U wave. And this is kind of a generalization, but the symptoms of hypokalemia can be a bit more subtle than those for hyperkalemia, which can onset a lot more rapidly. So does anyone have any questions related to that? So I'm going to comment on one of the questions from the chat, which was how much hyperventilation will actually happen with compensation. So that's a very good question, actually, and really is a balance between the respiratory drive due to hypoventilatory respiratory compensation is less effective than kind of hyperventilation, because there is a limit, and there is a respiratory drive by PaO2 acting as well. So it's going to be a balance of those factors. So the respiratory drive in response to PaO2, and then that also the hyperventilation related to trying to blow off that CO2. So yeah, in reality, it will compensate slightly, but of course it can't go down very much. So often those patients won't necessarily be completely compensated in the case of a metabolic acidosis. And you'll see that their pH is still lower. So hopefully that answers the question. But yeah, and do you have any suggestions of experimental evidence for potassium? I think for potassium, really, I don't really have any per se that I can recall, but I think for potassium, try to look for some more traditional experiments, but particularly there will be a lot of research literature on the clinical side in terms of treatments for hyperkalemia and hypokalemia. Maybe also look at whether there are any known, for example, ion channel mutations, which may relate to potassium handling. And there could be some experimental evidence related to those. But yeah, I'd recommend particularly looking on the clinical side, maybe relating to treatments for hyperkalemia, for example, because that sodium zirconium cyclosylate is, for example, a very recent GI binder which has been introduced. But yeah, hopefully that helps. Does anyone have any more questions? If not, I'll go on to a mini summary. And yeah, I think we'll probably have to end there. But I've got some slides on calcium and iron for everyone who gets the slides afterwards. So in terms of pH regulation, first of all, what we want to consider is that there's often two different forms of disturbance, respiratory and metabolic. And the body tries to compensate for those disturbances through three main mechanisms. So the immediate mechanism will be the action of the bicarbonate buffer system, other buffer systems in the body, other buffer systems in the body, such as alternative buffering systems, such as a phosphate buffering system, and binding to plasma proteins. We then also have respiratory compensation, where the ventilation rate is altered to either retain or get rid of CO2. And then finally, alterations in renal excretion. So we have the reabsorption of bicarbonate, excretion of protons, and to a lesser extent, potentially also the excretion of bicarbonate. When considering derangements, we want to look at, first of all, what the effect is on the pH, then you want to look at the PaCO2, and then you want to look at the bicarbonate. Also consider that there is for metabolic acidosis, calculation of the anion gap is very useful to try to infer what the underlying cause of the metabolic acidosis is. Then moving on to potassium regulation, remember that potassium is a very important intracellular ion, and it's particularly important for the determinants of the resting membrane potential and the excitability of cells. Dysregulation of potassium regulation can be due to impacts on ingestion, but particularly it's due to movement of potassium between compartments. So release from the intracellular compartment or translocation into the intracellular compartment, or problems with handling either the intake or or losses of potassium. And dysregulation to potassium is associated with the characteristic ECG changes. So that's the end of my slides on pH disturbances and potassium disturbances. If anyone has any questions, feel free to leave them in the chat. If not, thank you very much for listening.
Hello, just before everyone goes off, please, Karen, could you please go to the last slide with the feedback QR code? Because we have this lovely QR code for you so that you are able to give Kieran some feedback, which would be very, very helpful. And also we'll be much more keen to send you the slides
I do
once you've
have
sent the feedback in.
a final slide with a QR code. If anyone's still here, if you could scan the QR code and please complete this to get a copy of the lecture slides, that would be great, and give me some feedback.